As you can tell from the title, the focus of talk is changes that made by WHO in urologic pathology. Although WHO recently recognized those changes, but we as a pathologist have been using many of those changes for a while. But today I want to focus on the most recent changes and the one that we use in the daily practice. This is the cover page of the new WHO. In case you want to buy it as a Christmas gift for your colleagues, just remember that. WHO published in February this year, and basically is the framework of our reporting. International Society of Urologic Pathology, or ISUP, is the major contributing group in publishing this book. And as you can see, the previous edition was published in 2004, which is a long time ago. I want to start with the bladder cancer and the new changes in the bladder cancer. In general, urothelial carcinoma is through two main pathways. The low-grade urothelial carcinoma, which is present as 80% of the time, it's mainly through the FGFR3 mutation, and about 10% of the time there's a mutation in HRAS, which they are mutually exclusive. Either mutation of either in FGFR3 or HRAS can activate the RAS MAP kinase pathway and cause proliferation and create low-grade lesions. About 20% of the time, we have a high-grade urothelial carcinoma, which show mutation in P53 or retinoblastoma, or sometimes both together, which cause more aggressive tumor. And about 40% of the time, there is amplification or overexpression of the MDM2, which is again mutually exclusive with P53. Disruption of this pathway can cause disruption in a cell cycle, DNA repair, and apoptosis, and create a high-grade urothelial carcinoma. Urothelial carcinoma, it's known for recurrence, and that's why it's one of the most expensive cancer in terms of the management. About 15% of the low-grade urothelial carcinoma that recur acquire more mutation and progress to high-grade urothelial carcinoma. This is just a general and very simple genetic background for the urothelial carcinoma. Now, let's see what's the corresponding morphology classification. This is the classification tables for non-invasive lesions, and the left-hand side, that's the classification for the previous edition of the WHO, and the right-hand side, the new classification for current WHO. Essentially, they are the same. They classify flat lesion as a urothelial carcinoma in situ, high-grade lesion as a non-invasive high-grade papillary urothelial carcinoma, and the spectrum of the low-grade in both classification. But in the new edition, the urothelial proliferation of uncertain malignant potential and urothelial dysplasia, it's added to classification. Although some of us already use that, but I'm going to just focus on the dysplasia now. By definition, urothelial dysplasia is a flat lesion with cytologic and architectural atypia that falls short for diagnosis of CIS, or carcinoma in situ. It's felt that dysplasia is a perineoplastic lesion, but still the clinical significance of dysplasia is uncertain, and generally happen in a patient with a prior history of the urothelial carcinoma and rarely seen in de novo. I put some images for better visualization. This is the top panel is a normal urothelium, which has composed of 5 to 7 layers, polarized, and the umbrella cells on the top. The bottom panel shows the urothelial carcinoma with jumbled cells, architecturally distorted, and there was scattered high-grade hyperchromatic and large cells, which by definition is urothelial carcinoma in situ. In the middle panel, it's kind of in between. We have some mitosis in the middle, some hyperchromasia, and a little bit jumbled cells. And that's why it's short for the diagnosis of carcinoma in situ and categorized as dysplasia. Now, let's talk about the classification of invasive urothelial carcinoma. Again, the left panel is the classification for the old edition, and the right panel is the new edition. Essentially, they are the same, except in the old edition, urothelial carcinoma with different type of the differentiation basically lined up in each category. But in the new edition, they lump it together, and they call it urothelial carcinoma with divergent differentiation, because urothelial carcinoma is known for variety and combined differentiation at the same time. Although the classification of this urothelial carcinoma remains the same, but our knowledge based on the natural behavior of some of the variants are expanded. I'm going to highlight some of those variants for you guys. Here is the plasmacytoid variant, which is a diagnostic challenging. During the cystoscopy, it's not always you see the lesions on the surface, and rather often present as a bladder mucosa edema. For microscopic examination, also challenging for us, because with the one glance, it looks like a chronic inflammation. And that's why usually plasmacytoid variants present with the later stage and higher stage and have a poor prognosis. The other variant that I want to highlight for you guys is the nested variant. This nested variant is, again, a microscopic diagnostic challenge for us as well. The reason for that is usually the cells is very low grade and monomorphic, and sometimes it can be mistaken by a reactive process like a Wurm-Brand nest. This variant is also present with a higher stage and has poor prognosis. The other different type that I want to highlight here is urothelial carcinoma with squamous differentiation. Based on the cancer genome data, this type is subtyped as a basal type, and although it's very sensitive to neoadjuvant chemotherapy, but usually present at a higher stage, has a poor prognosis and radiation resistant as well. And lastly, the micropapillary variant, which often associated with lymphovascular invasion, lymph node met, and present usually at a higher stage. And this variant and has a poor prognosis as well. This variant, this one of the variant that HER2 overexpression happen most often in this type of variant. And in contrast to breast cancer, which HER2 overexpression is due to gene amplification, in micropapillary variant of urothelial carcinoma, HER2 overexpression is due to mutation. That's why FISH is not a good testing modality to assess the HER2 in those cases, and IHC has a better performance. Now I want to just touch on some of the incipient lesions or forms Frustes in the bladder. Most frequently, those lesions seen during the surveillance cystoscopy, and based on a microscopic examination, usually they are blunted or incomplete papillary formation. They may have thickened urothelium, and the cytologic ATPR could be low or high grade. These are some images that I put for you guys. This is a little bit thickened, or is one of the classification of the new WHO hyperplasia, or urothelial proliferation of uncertain malignant potential. In these lesions, we have a aborted papillae with some fibrovascular core and thickened of the urothelium. In this type, we have tenting of the urothelium, and there is no definite papillae as well. And here again, we have trying to make a papillary formation, but it's just thickened and there's some architectural distortion. I was learned that when we see those lesions, if the patient has a history of papillary neoplasia, the cytologic characteristic is low grade. We call it early non-invasive low-grade papillary urothelial carcinoma. And if the cytology is high grade, we call it high grade, early non-invasive high-grade papillary urothelial carcinoma. And for those patients that there is no history of the papillary neoplasia, and if the cytology is low grade, we call it urothelial dysplasia with early papillary formation. And if the cytology is high grade, we call it urothelial carcinoma in situ with early papillary formation. Now, let's move on to prostate cancer.
Peyman, did anybody ever talk to a clinician to see what they're supposed to do with all that? It all sounds the same to me.
It's a kind of semantic terminology, but as I mentioned, most of the time happen during the surveillance. And because we need to name and categorize and classify those lesions, basically, that's the classification. And as I mentioned, and probably you know better than me, urothelial carcinoma is very known for recurrence. And this is just shows that the patient needs to go under surveillance and more follow-up.
How often are you relying on cytology to find histologic?
Urine cytology, basically you're talking about urine cytology. Urine cytology is a good screening, but the sensitivity is about 60 to 70%.
The specificity is pretty low.
Specificity for high-grade lesion is very high, but for low-grade lesion is very low. That's correct.
He's talking about cytologic appearance, not cytology.
Yeah.
Oh.
When I talk about those lesions, I'm talking about the cytology of the lesions itself. In prostate cancer, intraductal carcinoma, I want to touch on intraductal carcinoma. In 2004 WHO, it wasn't recognized. And 2016, it's recognized, and basically by definition is intraacinar or intraductal proliferation of neoplastic cells that, based on the cytologic and architectural atypia, it's greater than high-grade PIN, and usually associated with high stage and high grade prostate cancer. We don't grade intraductal prostatic adenocarcinoma, and but it's an independent predictor of poor outcome. It's usually associated with P10 loss, and rarely presented with only low-grade carcinoma. And when the diagnosis of the intraductal carcinoma happened in the biopsy, it needs definitive therapy, or at least immediate repeat biopsy. Next stop is I'm going to briefly talk about the Gleason grading system. Last update in Gleason grading system was in 2014, and basically codified what was already in practice. But WHO recommend to use grade grouping in association with Gleason grade as well. There are 5 grade grouping, and grade group 1, which is the best grade group, is Gleason score 6 and less, and grade group 2 is Gleason score 3+4, and grade group 3 is Gleason score 4+3, and grade group 4 is Gleason score 8 in total, and grade group 5 is Gleason score 9 and 10. This grade grouping initially introduced in 2013 by Epstein Group in Johns Hopkins, and they followed about 8,000 patients with radical prostatectomy from 1982 to 2011. And this graph just shows the Kaplan-Meier of the biomedical recurrence-free survival. And they showed that based on the Gleason score, they can stratify those patients in 5 groups. Later on, 20,000 patients with radical prostatectomy followed, and to verify this grade grouping in 5 different institutes. And once they verified this grade grouping, WHO recognized that and acknowledged the grade grouping system. And what's the advantage of the grade grouping system? I guess the biggest advantage for us is still based on the Gleason score, and that means there is no change for us. That's a good thing. The other advantage is primarily help patients and clinicians to recognize that Gleason score 6 is the lowest and the best tumor that the patient can have. It's not an intermediate intermediate cancer, and also highlights the significant difference between Gleason score of 3 plus 4, 7, and versus 4 plus 3, 7. That's why it's recommended by WHO. For the sake of the residents, I actually put some of the images to remind them about the different grade group and Gleason score. This is grade group 1, which is composed of individual small glands. This is grade group 2, which has mainly individual glands and some cribriform glands here and probably fused glands here. And this is grade group 3, which predominantly contains cribriform glands and some individual small glands as well. Grade group 4, it's mainly cribriform in these figures, but it can be all fused glands as well. And lastly, grade group 5, it's composed of fused and cribriform glands and single cells and cord-like cancer cells. The other recommendation in WHO is reporting Gleason pattern 4 when there is a Gleason score 3 plus 4. And the reason for that is basically helps to select active surveillance candidates. The cutoff for Gleason score 4, it's not mentioned, but based on the different research and I guess based on the different patients' characteristics, it's going to be different. But in general, they call it if there is a Gleason score, Gleason grade 4 less than 20%, patients still can be under active surveillance. I put some of the current reporting system that we used to use in Cornell. In Cornell, mainly we report for individual cores. Some of the pathologists here also report individual cores, but most of them they report as a summary. Basically, we call it individual cores, prostate adenocarcinoma, and we mentioned the grade group, and in the bracket we call it Gleason score, and we mentioned the percentage of and the length of the involvement of each individual course. And at the end, we call what's the percentage of the Gleason pattern for in the core biopsy. This is the method that they use in Sloan Kettering. It's almost the same, but it's kind of in the point format. Now, we're moving.
Can I ask you a question
Sure.
on prostate before you move on? Intraductal is actually a bad prognostic. So
Correct.
you mentioned that. You don't really see it that well in thin sections. You can see it in breast, at least. They found it much higher incidence of intraductal when they did thick section of the tumors. And there's been a couple of papers looking at that in prostate. So when you look, I mean, it all depends on how you cut through the tumor to see it inside of it, to see whether or not the cancer's in the gut. How often do you think you're missing intraductal on thin sections that we do? Would be question number 1. And question number 2 is, where does intraductal fit into the Epstein grading system?
Okay, I answer the second question first. We don't Gleason grade intraductal. Intraductal is still it's not a cancer, and it's just a poor prognosis.
Yeah,
And
if you have a 3 plus 4 with intraductal, you're not going to actively survey that.
yes, that's correct. That's why when there is an intraductal carcinoma diagnosed in the biopsy, that means the patient needs to go. It's not active surveillance anymore. The patient has a definite treatment, and intraductal usually often associated with high grade and high stage. And when there is just intraductal in the biopsy, and we don't diagnose any other cancer, or maybe just a 3-3 cancer, then that means the patient needs another biopsy at least to prove it there's a higher grade, or it needs a definite treatment. To answer your first question, I'm not sure exactly about the cut sections. For sure, during the processing of the section of the biopsy, we may lose it, but I doubt it that we're gonna lose at all. It's still diagnosable during the biopsy.
I'll email you some papers.
Okay.
Another question on prostate. That's, I think the current groupings are certainly clarify a lot of the issues around Gleason, but still there's an issue with group 2 and group 3, where, for example, you could have multiple cores, and we've seen this recently. In one core, a 4+3, but you've got 4 other cores of 3+3.
Mm-hmm.
So how would you grade that? Which group would that person go into?
This is a very good question. Based on a WHO, their recommendation is we need to report each core individually and grade group it individually. But at the end, we can summarize and give the total or overall Gleason score or grade grouping. And I usually do that. I do the overall grade grouping and highlight the highest grade grouping as well in the summary.
One other corollary with that is that you could have a single 4+3 that is a risk group 3.
Correct.
And yet you could have another who has 5 3+4s and be in risk group 2, even though volume of 4 is much greater in the latter than the former. So I guess that there's still...
Because I guess the difficulty and challenging is because, as you know, prostate cancer is very heterogeneous and multifocal. And sometimes maybe we have different nodules in the prostate and the biopsy is from a different area. But I guess at the end of the day, the highest grade grouping is going to be, I guess, is going to be is going to dictate the management of the patients. Move on to the kidney. I'm going to start with the papillary adenoma. Based on the 2004 definition, papillary adenoma was unencapsulated low-grade papillary lesion with a size of less than 5 millimeter. In the new definition, the size criteria has changed and went to 1.5, less than 1.5 centimeter. And the reason for that is based on the MSK and Mayo Clinic data that they showed those tumors that is less than 1.5 centimeter, they have no metastatic potential. The other change based on the terminology is multilocular cystic renal cell carcinoma, which by definition is a cystic tumor lined with low-grade clear cells without any expansile nodule. The definition in 2016 remained the same, but they changed the name to multilocular cystic renal neoplasm of low malignant potential. And basically, these type of tumors related to clear cell renal cell carcinoma, the mutation in VHL and P3 deletion, has a similar rate to like a clear cell renal cell carcinoma. But they followed more than 200 patients with this type of the diagnosis, and they found there is no recurrence or metastasis. That's why they get rid of the carcinoma and they call it neoplasm with low malignant potential. There is a new entities for renal cell carcinoma. I divided based on the poor prognosis and good prognosis. Hereditary leiomyomatosis and renal cell carcinoma syndrome associated renal cell carcinoma, which is a very mouthful term. It's already discussed 2 weeks ago here by one of the speakers, and this is one of the hereditary that has a poor prognosis. For good prognosis, the new entities, the first one is also could be hereditary with a germline mutation of SDH, and but it's an indolent tumor. For the other tumor, I'm going to explain it here in these slides. These all tumors are indolent and has a good prognosis. First, with the clear cell papillary renal cell carcinoma, which is different entity from the papillary renal cell carcinoma, has an indolent behavior, and there is no chromosomal abnormality like a papillary renal cell carcinoma. And based on so far there is no report of metastasis for this tumor, and I assume that by next edition of the WHO probably they're going to change this to clear cell papillary neoplasm rather carcinoma. The other tumor is tubulocystic renal cell carcinoma. This is based on the chromosomal abnormality related to papillary renal cell carcinoma, but has a better prognosis and has an indolent behavior. And lastly is the acquired cystic disease-associated renal cell carcinoma, which happened in the end-stage renal disease. And these tumors also has an indolent, and no metastasis has been reported unless there is a sarcomatoid or rhabdoid differentiation within the tumor. That's changed the behavior of the tumor as well. The next stop is a new grading system of the renal cell carcinoma. In 2004, there was a Peyman grading system, and Peyman nuclear grading is based on the nuclear morphology and the size of the nucleus and the presence or absence of the nucleoli in different magnification. The new WHO used the WHO or ISUP nuclear grading, which mainly is based on the size of the nucleoli in different magnification for the first 3 grades, and the polymorphism of the nucleus for the grade 4. This new grading system is more robust and provides better outcome prediction. Reflects what was already in practice, at least in VGH and BC Cancer Agency, and like Peyman nuclear grade, validated only on clear cell and papillary renal cell carcinoma. It's not validated for other type of the renal cell carcinoma. I put some images for different grade group based on the WHO or ISUP nuclear grade. The first one is grade 1, which the nucleoli cannot be appreciated even in higher magnification. This grade nuclear grade 2, which you can appreciate some nucleoli and appreciable in higher magnification of microscopic examination. Nuclear grade 3, it's even in a lower magnification, nucleoli can be appreciated. And nuclear grade 4 has a polymorphism of the cells and large cells. Lastly, it's going to be testicular tumors. Intratubular germ cell neoplasia of unclassified. By definition, it's an intratubular proliferation of gonocyte-like germ cells that has a clear or pale cytoplasm with hyperchromatic and enlarged nucleus and prominent nucleoli. Based on the definition, definition remains the same, but they changed the name to germ cell neoplasia in situ. And there is a funny story behind that. Basically, European community, they used to call this lesion carcinoma in situ, which is a wrong term because we know that these are not epithelial cells, it's a germ cells. And European community, they didn't like the terms unclassified here because they thought that this is a confusing term. And that's why they mixed both terms together and come up with a germ cell neoplasia in situ. And this is the recommendation terminology for WHO. And lastly, spermatocytic seminoma, by definition, is a germ cell tumor resembling spermatogonia or early spermatocytes. The definition in the new WHO remains the same, but they changed the name to a spermatocytic tumor. And the reason for that is because they don't want to confuse people with seminoma because they are two completely different biology. The spermatocytic tumor, there is no malignant potential unless there is a sarcoma component in there. There is no association of this tumor with germ cell neoplasia in situ. Does not occur outside the testis, and it's not occur in the prepubertal conditions. And there is no association of this tumor with cryptorchidism. And this was my last slides. I guess I went too fast. Yeah, it says something just not right. Our air is clean, our water is pure, we all get plenty of exercise, everything we eat is organic and free range, and yet nobody lives past 30. These are the two cavemen discussed.